Yeah.
All right.
Very good. I would always keep the liquor.
All right. Thank you all for coming. Very much for coming. Welcome, everybody. My name is Lisa Yarnovich, and my presentation today is on the Framingham risk score versus the calcium score. So I know a lot about the calcium scores because I do them every day, so I know a lot about the reasons why people come to have them and what the following steps are depending on what the score is. Today I'm going to show you the difference between the Framingham risk score and the calcium score and how each one can determine a patient's risk for heart disease together and apart. Here's a little bit about what I'm going to show you. Good? Okay. So I want to start with a question. What is atherosclerosis? Does anybody know, want to venture a guess? Does anybody have any idea what atherosclerosis is? Plaque in the vessels, perfect. So atherosclerosis is a disease of the vessels, disease of the arteries. And here on the left, we see a normal artery, so oxygenated blood is going to flow freely to the heart. And on the right, we see a blood vessel with plaque or fatty materials built up in it. How does that happen? Well, that happens when the inner lining of the artery, called the tunica intima, becomes damaged. Once it becomes damaged, it allows atherosclerosis to begin. So, what kind of things damage the vessel? Things like high blood pressure, high levels of sugar in the blood, toxins, viruses, immune reactions, all things like that can damage the lining to that vessel. So this is kind of a busy slide. There's a lot going on, and the physiology is pretty in-depth, but I'm just going to go over a basic 4-step process to fatty streak. What is a fatty streak? So a fatty streak is actually in step 4, you're going to see fatty streak, and it's the first visible sign that you can see with the naked eye. You don't need a microscope to see it of plaque buildup. It's yellow-white tinged on the inner lining of the artery. So step 1 is the artery becomes damaged by some of the things that we talked about earlier, like high blood pressure, diabetes, smoking. At that point, LDL becomes trapped in that area. Low density lipoprotein is going to become trapped. So that's step 1. Step 2 is endothelial dysfunction. And what happens there is your monocytes and your T lymphocytes will come to that area and start infiltrating the vascular intima. In step 3, you have leukocyte activation. So what's happening in this step is your monocytes, your mononuclear leukocytes, your T cells, all of that is coming and actually breaking through the cell wall at that point. And then in step 4, your foam cells are forming. Foam cells are cells that contain cholesterol, and those are the cells that can cause plaque. So what's happening here, there's a few things going on here. Your mononuclear phagocytes will turn into macrophages. You're going to have to think back to like anatomy and physiology with this. So your macrophages are going to help absorb and accumulate some of those lipids. And in addition to your phagocytes, they're undergoing phagocytosis, so they're helping to deter the atherosclerosis by consuming the lipids. At the same time, the HDL, which is high density lipoprotein, it's your good cholesterol, that's coming in and that acts as a scavenger to take the LDL away. So what it'll do is it'll carry the LDL away to the liver where it can be rid from the body. And has anyone ever heard of keep your HDL above 60 and your LDL below 100? That's why, because the HDL acts as a scavenger. And so, but at this point, if more lipids are entering this area than can be taken away by phagocytosis or macrophages or HDL, then the atheroma can form, and atherosclerosis will at that point be kind of out of control. So here we see a picture of a heart and a coronary artery disease. So in the top we have a normal coronary artery, blood flows freely to the heart. In the middle picture we have a picture of atherosclerosis. So if the plaque builds in the vessel and then stops growing and stays right there, usually there's not a problem because blood is still going to be able to get through and do its thing. In the bottom picture, we see plaque, and what can happen to the plaque is it can rupture. If the plaque ruptures, then at that point, your platelets are gonna aggregate into that area. They're very sticky, they stick together, and that's when they can cause like a life-threatening crisis. So blood clot's gonna form, heart attack, stroke, because the blood can't get to the heart. Atherosclerosis can occur in any of the arteries in the body, any of the arterial tree. However, it's most common in the high pressure arteries. What kind of contributing factors contribute to atherosclerosis? There are a few. Smoking and advanced age are two of the biggest ones. Smoking, because of the toxins in the smoke, damages that lining. And with advanced age, they're still doing a lot of study. They don't really know the exact causes of why advanced age and atherosclerosis affects atherosclerosis, but what we do know is that it starts in our teens, crazy, right? Mm-hmm. And doesn't become typically symptomatic until late 20s, early 30s, and then grows as we get older. So as we get older, it hardens, it gets more increased, and it causes obstructions of blood flow. So some other contributing factors are high BMI and high cholesterol. So high BMI is body mass index, and a normal BMI is 18.5 to 24.9. 25 to less than 30 is considered overweight. Over 30 is considered obese, and then over 40 is considered morbidly obese. So the reason that high BMI contributes to atherosclerosis is because it causes things like diabetes, hypertension, and cardiovascular issues, because we're not eating a healthy diet, we're not fit. It doesn't mean that skinny people can't get atherosclerosis, quite the contrary. Just having a high BMI makes you more at risk for it. With high cholesterol or hyperlipidemia, you might hear that term. That's the regular term, hyperlipidemia. You'll hear your doctor say that. What that is high levels of protein fat in the blood. And the normal level, they want total cholesterol below 200. Anything 200 to 239 is considered borderline high, and anything over 240 is considered high. And then again, LDL you want below 100, and HDL you want above 60. Last contributing factor we'll talk about is genetic predisposition. So it's really something important to think about. Genetic predisposition, there's been a lot of studies on it, and it accounts for 40 to 60% of the risk for coronary artery disease. So it's definitely something you can't ignore. Family history can include family history of coronary artery disease, a family history of peripheral vascular disease, a family history of diabetes, hypertension. And then what is a family history? A family history is actually any first degree relative, age less than 55 for men and age less than 65 for women. So if dad had a heart attack at 50, or peripheral vascular disease, or if mom had diagnosis of coronary artery disease at 60 or had a heart attack at 60, first degree relative, brother can be included in that as well. So definitely something you don't want to ignore. And again, you can be fit, you can be healthy, you can do all the right things. Eat a heart healthy diet, exercise. If you have a genetic predisposition, you're still at risk and should definitely get checked out. So we're going to talk a little bit about the Framingham risk score. So the Framingham risk score, does anyone know what it is? Any clue? I didn't either until I started really doing research on it. So the Framingham risk score is a gender-specific 10-year risk assessment that's done by your clinician in the office to determine a patient's 10-year risk for heart disease. The guidelines were created and set by the National Cholesterol Education's Third Adult Treatment Program. It's a mouthful. They call it ATP3 for short. And it was created in 1998, and we've had two updated versions, one in 2002, one in 2008. And clinicians tend to use the one that's from 2008. That's the one they typically tend to use. So what this does is it puts patients in a low, intermediate, or high risk category. So I'm going to let you hand out some forms here. Pass these around. And everyone take one of these and just look. If you look online, there's only a few here. If you look online and you Google Framingham risk score calculator, you're going to come up with a dozen results. They're really common. I really liked this one because it was easy to read and colorful, and I think anyone can really do it for themselves and plug in the numbers and figure out where they are falling in the risk category for heart disease. So like I'm gonna take me for example, so I'm 49, so if you go up the middle is age, and then up the left side is systolic blood pressure, down the bottom you're going to see cholesterol, and then it breaks it down into men and women, smoker, non-smoker. So for me, 49, I just went up right below 50. My last systolic was 130. You come over to the left, non-smoker, and my cholesterol was 194. So that would put me at a 0. So my doctor would probably say, you're good, you're in the low risk category, you don't have to worry about anything. And you can do that for anyone. And like I said, if you Google this, a lot of different charts will come up. And I actually have one other chart that I went ahead and wanted to show you, because I like this one on the bottom. Obviously the numbers are really small and you can't see it, but on the bottom you can see less than 10% puts a person in low risk, 10 to 20% is intermediate risk, and then high risk is over 20%. They also have online calculators, so if you don't want to have to worry about a chart, there's a lot of these online too, and this would be Framingham Risk Score online calculator. And what you do is you plug in all the information, and then you hit calculator on the bottom, and it gives you your percentage of risk for heart disease. And the thing that's different about these with the charts is that on these online calculators, they will ask if they are hypertensive on treatment, and if some of them ask if they're diabetic on treatment. This particular one asked about hypertension. And we're going to go forward, and I'm going to show you a couple examples of some patients that we did. So this was a 49-year-old man, 115 total cholesterol, HDL was 33. He was not hypertensive, his systolic was 100, and he was not a smoker. So when we plugged his information in to the Framingham Risk Score online calculator, it comes up at, you can see on the bottom, so everyone see 2%. So what would he be? Low risk. He came in at his wife's urging. They had just lost a family friend, close family friend, to a heart attack. His wife urged him to come in for a calcium score. The only history he had no family history, and he was obese, morbidly obese, was the only thing. His calcium score was 230, which put him in the 96th percentile for his age and gender. So what that means is that even though he's low risk, he now knows he's got atherosclerosis, he's got plaque buildup in his vessels, and this can help him to know, okay, maybe I need to make some lifestyle changes, maybe I need to go on a low-dose statin. These are things that he can talk about with his doctor, whereas before that conversation probably wouldn't have happened. Okay, and then I'm going to hand out one more chart for you. So this chart, right here, like we said earlier, the Framingham Risk Score has guidelines that it bases the results on. And the calcium score does as well. This chart shows on the top two lines the guidelines for the Framingham Risk Score, in addition to adding the calcium score. And what this shows is it can help, adding the calcium score can help stratify, reclassify a patient's risk either up or down depending on the calcium score. I'm going to show you an example of that. So here's another gentleman who was 59. Total cholesterol was 167, HDL 48, and he was under hypertensive treatment. Systolic was 142, and he was not a smoker. So his Framingham Risk Score was 12%. So based on the calculator, he would be intermediate risk, okay? So if we look at this chart right here, would he need a statin or not? Yes, because he's greater than 7.5 and to 20. So his doctor would probably say, here you go, here's your statin, let's keep an eye on you. He came in for a calcium score. He had some new diagnosis of AFib and hypertension. No family history. Yeah, no family history. His calcium score was 0. No calcium, nothing showed up. So looking at this, now when you have a calcium score that's 0, it's not recommending a statin. So he has the benefit of knowing, hey, I don't have to take the statin if I don't want. Now, obviously, him and his doctor could discuss that, and that's something he may still want to take a low dose, but because of this test, it really helped to reclassify him and give him more information. Whereas the other gentleman, his score was 2%, a statin was not recommended. He had his calcium score, it was 230, a statin was still not recommended on him. But he has now knowledge to know, again, like I said, that maybe he needs to kind of keep an eye on that because he does have it, and he needs to probably just make some lifestyle changes.
Well, now, I'm trying to figure out is it just being hypertensive that gave him such a higher?
And he was 10 years older.
Okay.
And he was 10 years older, so age definitely plays a factor in that.
But weight did not, considering he wasn't considered morbidly obese like the other.
No, and weight doesn't even factor into
Okay.
these. They don't even ask for weight in these calculators or the charts at all. But yeah, hypertensive on meds, and then if you add on that a smoker, and I've got a couple coming up that you'll see, smoking definitely increases your risk on the Framingham side. But age, I think we had done one for Stacy's husband, and he's got some risk factors, but because he was just 40, it was very low. But in 10 years, if he has those same risk factors, it jumps up to like intermediate med risk, okay? So the calcium score, I'll talk a little bit about the calcium score. So it is named after Dr. Arthur Agustin, because it's the Agustin score, but they call it the calcium score. So Dr. Agustin is a cardiologist in Miami, still practicing, and Dr. Warren Janowitz is a radiologist still practicing in Miami. And they got together back in 1990 and developed this score. It was out of a keen interest in preventative care that Dr. Agustin wanted to do this. He wanted to be able to measure calcium and reproduce it each time. And so they got together and they created this. It's actually one of the most commonly used methods today because it is one of the most reproducible ways to measure calcium. There's been a lot through the years, and this one has really stood the test of time. Calcium score. Anyone ever have a CAT scan? Does that look familiar? Mm-hmm. So a CAT scan, this is similar to the CAT scan machine that I have. It's a somatome sensation. This is a cardiac. I have a definition, but I have the cardiac software. This is an actual cardiac scanner. But how it differs from a regular CT machine is that we have up here, we have an area. We hook a patient up to 4 ECG leads, and it attaches to the scanner, and we can actually watch their EKG and their heart rate. And so what happens is we scan the patient, supine, arms over their head, just to get the arms out of the way, and we do a quick picture through the heart, above the heart, just down through the bottom of the heart muscle. And once that's done, the software will take the images, because obviously you've got a beating heart, they're holding their breath, but sometimes they can't hold it really well. You're gonna have some motion. The software takes the images and uses only the images at rest. And so we have less motion and we're able to quantify that calcium a lot better. The reasons people come for these types of CTs, calcium score is typically done on asymptomatic patients. Asymptomatic only. I do a couple that have had chest pain, but typically asymptomatic is when you're coming for this test. Family history of heart disease, family history of high cholesterol. I have high cholesterol. I have a new diagnosis of high cholesterol. I'm on a statin. I can't take it anymore. My doctor wants to put me on a statin. I don't want to take it. So they'll come here for this test. Or they may have had another chest x-ray or a CT scan or an MRI and they saw plaque. And so now doctors sending them here for this to go ahead and get this scored. Here we see 3 images. When I'm taking the CT images, I'm getting a lot of images through the heart. We have just 3 right here. And this is on the left, the normal heart. And so what we can see here, the LAD, and that's also known as the Widowmaker. And that's a normal scan. So that gentleman's gonna have a score of 0, no detectable calcium. In the middle, we have moderate calcification. So depending on this person's age and risk factors, they may or may not have to be concerned. If that's a 30-year-old, probably yes. If that's an 85-year-old, probably no. On the right, we have severe calcification, and more than likely, the moderate and the severe, more than likely they will be going for further testing. We'll talk about that as we get a little bit further in. But we measure more than just these vessels, but I liked these pictures because they gave you a good indication of kind of what we're looking at when we're seeing the CT images and what the doctor, the cardiologist actually has software on their computer, and we send those images over to them and they're able to plot any calcium they see, and then it comes up with a score. So just like the Framingham risk score has guidelines, the calcium score had numbers, but they didn't know, they had to put kind of what does each number mean? They had to assign it a risk level, and so they put 0 is no risk, none identified, and that's known as the power of 0. So this means if you get a 0, you can pretty much say, okay, phew, breathe a sigh of relief. Anything 1 to 10 is considered minimal. Risk 11 to 100 mild, 101 to 400 moderate, and then anything over 400 is considered high. So, limitations. What are some limitations of the Framingham risk score? The Framingham risk score has a few limitations, and what it does is it measures future coronary artery events, but it does not measure events. It doesn't measure whether someone can have a stroke or whether someone's going to have a heart attack or anything like that. Also, there's been a lot of population-based studies done on the Framingham risk score on older adults, and they have found that it underestimates women by 51%. Underestimates women by 51% in older women, by 8% in men. So because of this, the Framingham risk score needs to be used with caution in older adults.
Is there a reason why it would underestimate for women, older women? I mean, because you would still see the same amount of plaque, correct? Or, well, I guess
It's
because
the framing, we're talking about the Framingham
you
risk
just be
score.
taking
It's just
their
it's just
histories.
this, yeah.
Right, so you just be taking
Correct.
their history.
Correct.
Oh, okay.
Yes, not the calcium score.
Okay.
So the calcium score does have a few little weaknesses, and one of the biggest ones for me is that it's only considered preventative care by insurance companies. And so insurance companies are not covering this service. It's not a covered service like a lipid panel or a blood glucose panel would be through insurance. So because of this, these are offered at a very reduced rate, but a self-pay. With that being said, a lot of people can't afford it, and so we miss probably a lot of people that should be diagnosed that are not, because it's a self-pay exam. If this calcium score is done on a scanner that does not have cardiac software, and they're not hooked up to the leads, you're going to get more motion in the scan. The calcium can still be measured, but it may skew the score. Also, Dr. Agustin and Dr. Janowitz set parameters for the score at 3 millimeters, so we scan in 3 millimeter by 3 millimeter increments. If a technologist were to come in and change those parameters to 1 by 0.6 or 2 by 2, it could lead to oversampling and lead to a skewed score. So those were just 3 small weaknesses of the calcium score. So what's next? You have a high calcium score, it can be terrifying, it can be very scary for people. Oh my God, am I gonna have a heart attack? What do I do? How do I fix this? So the next few slides, we're gonna talk about some options, some further testing that patients can go through if they do find that they have a high calcium score. So here we see a picture of a stress test. And so a stress test is typically done with symptomatic patients. If someone's having chest pain, they're probably gonna go for a stress test first. However, we have done calcium scores first and then a stress test if they have a high one. We've done stress tests first and then a calcium score after. So it really just depends on the patient, the doctor, what's going on. There's so many variables involved in that. But typically with a symptomatic patient, and what is happening here is they hook them up to a 12-lead EKG, and their EKG is watched while at rest, and then they are put on the treadmill to exercise, and they exercise anywhere from 3 to 15 minutes depending on their tolerance for the exercise, and the EKG is monitored. If there are abnormalities in the EKG, it's considered a positive finding, and if there's no abnormalities, then it's considered a negative test. Typically, patients will, like I said, come for a calcium score before or after. I was going to say something. Anyway, so So that's the stress test. Oh, and it looks for basically blood flow issues to the heart. That's what it's looking for. It's looking for any abnormality in the heart wall, and it's looking for blood flow issues. So if you have a high calcium score and you go for a stress test, they just want to make sure that calcium's not blocking the flow of blood to the heart. So this was a 60-year-old former smoker, family history of coronary artery disease. Her Framingham risk score was 7.9%, had a calcium score of 1594, put her in the 98th percentile. Left knee had a stress test. Stress test was negative, so no blood flow issues because of that, thank goodness. So what they're gonna do for her, statin use and lifestyle modification, and continue to monitor the calcium.
So the statins are not gonna reduce the amount of calcium she already has, it's just hopefully to reduce the buildup?
Right, and there's been
more?
tons and tons of studies. This is kind of just a very basic rundown. There's like a plethora of studies and knowledge of whether statins are actually good at reducing that. I don't think so, but I think it's more a matter of let's slow the progress and try to prevent that from continuing. So another test that a patient might have is a myocardial perfusion. There's a lot of images here going on, but what this is imaging blood flow to the heart at stress and at rest. So a patient can come for a myocardial perfusion again before a calcium score or after a high calcium score. They may come straight if they're having chest pain. They might have a myocardial perfusion if they're having a pre-op testing because they're going to have aorta repair or a really intense surgery that they need to make sure that the heart's going to withstand the surgery. They want to make sure the blood flow is okay to the heart. If you have a high calcium score and they're concerned about it, they'll send you for a stress test. If the blood flow is good to the heart and it shows no abnormalities, then they know that that calcium is not really causing an issue at this point. Myocardial perfusions are actually 90 to 92% accurate. So it's a good test to have. This lady, 67-year-old female smoker, hypertension on meds. Framingham score was 22.84, and you had asked about that earlier. So her score is high. She's got hypertension and she's a smoker, and she's older, 67. So here we're really going to see that Framingham risk score start to rise. So she's in a high risk category, but she's over 20. Calcium score was 376. She was in the 92nd percentile. They sent her for a myocardial perfusion just to see if there was any blood flow issues, and she did not. Her myocardial perfusion was normal, and so what they'll do is continue to monitor her, obviously keep on taking a statin if she's not, and aspirin, whatever her and her doctor decide, lifestyle changes. A third test is a heart catheterization. So this is an outpatient procedure typically, and what's happening here is it's a surgical procedure, and they go in either your radial artery or your groin, and they're going up into the heart, and they're using IV contrast, some sort of contrast agent to look at the vessels in real time, so they can see blockages in real time. They can put stents in if they need to. They can see if a patient needs to have further things like bypass surgery or anything like that. So this gentleman was real interesting. He was a 67-year-old male, non-smoker. He had no strong family history, but he was symptomatic. He'd been symptomatic with chest pain and right shoulder pain on and off for a while. He had had a recent fall, the 10-foot fall off a ladder. So he had been going in and out from the doctor with this chest pain. Obviously, his Framingham risk score was only 11.9%, so only intermediate risk, not too bad. Calcium score was 2913, 98th percentile. And I will say that as he's going back and forth to the doctor, they ordered a right upper quadrant ultrasound to look for gallstones. They sent him to the orthopedic doctor because his shoulder, because he was having right shoulder pain, it was hurting him after eating. Orthopedic doctor said, I'm not going to inject you, I want you to go back to the doctor. Girlfriend calls, because the doctor had said, hey, if you're concerned, you can go have this calcium score. Says, I really want to get him in, So we get him in, and obviously the score was very high. He continues to have chest pain. They put him on a statin and an aspirin. 2 days later, he went to the ER. The next day, he had a cardiac catheterization and an echocardiogram. It showed severe two-vessel coronary artery disease and of his proximal left anterior descending and his left circumflex artery. 3 days later, he was in open heart surgery. So, Framingham risk score, 11.9%. It turned out really well for him though. So, what kind of things can we do if we want to try to avoid the whole atherosclerosis? Heart healthy diet, things like nuts, seeds, avocados, healthy oils, oily fish, fruits, vegetables. Good fats. Stay away from those saturated fats. Exercise. If we exercise and keep our BMI down, that helps with keeping hypertension down. Aspirin use if necessary, if recommended by the doctor. Statin use if necessary. And above all else, quit smoking. Any questions? Well, I hope you all enjoyed and learned something today about the.
Go back over this, read this
Yeah.
message for me again, how you do that?
Put
Get
your
the
glasses
score,
on.
get
I
the
will.
score.
Say that, no, go ahead, what is it?
The score, give me a score again, you said 49. You go
Okay,
by
so go
49.
up the middle to 49,
Right,
and then go left for female, non-smoker, keep going left. You
okay,
see up the left-hand side, there's systolic pressure.
right, mhm.
I think mine was 130 when I was there in May.
Okay,
So, and then my total cholesterol was 194. So if you look in this bottom right here, Tammy, this bottom right has the chart.
Oh,
So anything
150,
between 150 and 200 is a 5.
okay.
So I
see.
come up the
Okay.
bottom 5 because I was 194,
Oh,
and that's
okay.
where I got my 0.
Okay, then, okay.
That makes sense.
All
And
right.
then I have some references for you.
Well, thank you.
Thank you.
All right.